and I am clicking the Start Broadcast button.
The broadcast is now starting. All attendees are in listen-only mode.
Greetings. I am Dr. Deborah Fennell, and it's my pleasure to welcome you to the International Nurses Society on Addiction's new webinar series that focuses on the use of opioid therapies for treatment of opioid dependence and on the safe use of opioids in treatment of chronic pain. This series is one of many resources made available to the prescriber's clinical support system, Opioid Therapies, a program that is funded by the Federal Center for Substance Abuse Treatment and operated collaboratively by 6 other partner organizations: the American Academy of Addiction Psychiatry, the American Psychiatric Association, the American Medical Association, American Osteopathic Academy of Addiction Medicine, American Dental Association, and the American Society for Pain Management Nursing. I'd like to start with a quick housekeeping items before we get to today's presentation. In the upper right side of your computer screen, you will see a control panel. In the lower portion of that panel, participants can type in a question or comment and submit it to the webinar organizers. You can do that at any time during the presentation. We will reserve about 10 minutes at the end of the presentation for questions and answers. If we are unable to get to all your questions in the allotted time, Dr. Lorman has agreed to respond to them in writing. The webinar, presentation slides, and Q&A will be posted on our website in the near future. Today, Dr. Bill Lorman will address the neurobiology of addiction and pharmacological concepts. He will review the neurobiology of reward and pleasure, some contemporary theories and models of drug addiction, and genetic factors involved in the development of chemical dependence. Dr. Lorman is a certified addictions registered nurse at the advanced practice level. He is also board certified as a psychiatric mental health nurse practitioner. He is the immediate past president of the International Nurses Society on Addiction and currently serves on our finance committee and is the chairman of our nominating committee. As Chief Clinical Officer at Livingren Foundation Incorporated, he is responsible for all medical, nursing, and counseling staff, along with all programming for this multi-site inpatient and outpatient chemical dependency dual diagnosis facility. Dr. Lorman is a clinical assistant professor in the graduate nursing department at Drexel University. His primary role is teaching in the master's and doctoral nursing programs. I'd like to give a warm welcome to Dr. Lorman and turn it over to him.
Okay, thank you very much, Dr. Fennell, and good morning and good afternoon to everyone. We have about 50 minutes, I guess, to talk about neurobiology, which for most people is a very, very, very boring subject, but I'll try to make it as creative and lively as possible for you. And I know that we have a full range of participants listening in, so hopefully my goal is that you'll get at least one new piece of information out of this presentation, so that everybody will have that goal. That's my hope. So I'm going to start with some basic information. Okay, some facts about addiction. Addiction affects 22 million Americans. 75% of addicts are in the workforce. Now, that's the first myth breaker right there. We generally, as a rule, don't expect to find a heck of a lot of active addicted people in the workforce, and they are. They take up 75%, and pretty much a good number of the very folks that we work with in healthcare that work next to us side by side could, in fact, statistically have an active addiction. Only 9% of Americans who need treatment receive it. New medications can help control craving, an important issue right there for folks that do not believe that medications are available. Also, the next one is pretty much a myth breaker. Relapse is a normal part of the disease, just as relapse occurs in hypertension, diabetes, asthma. It also occurs in chemical dependency. And the last I call it a myth breaker because most people don't believe it. Treatment can, in fact, work. Substance-related problems. Now, this information comes from the World Health Organization. Substance-related problems are the third leading cause of death in the United States. Alcoholism causes 80% of cases of hepatic cirrhosis. There's an increased incidence of HIV and sexually transmitted diseases. And patients injured while under the influence fill 50% of U.S. trauma beds. This also comes directly from the World Health Organization. 7 of the 10 leading causes of disability in the world. And if you notice, 7 of the 10 all affect either primary psychiatric, primary substance use, or a combination of those two areas of disorder or disease. So a very tremendous issue for us in working with this population. Now I throw this up here, the alcohol intoxication chart. Most people are very much aware of this. I always ask my students, in your particular state, what is the cutoff for DUI? The point that I want to make with this is this particular chart. Most people think it's a clinical chart. It's not. It's a forensic chart. It's a legal chart. This chart is really only accurate for alcohol-naive people. So people that are under the influence that, for one reason or another, are in an active alcohol addiction and have high tolerance, they could very much have a BAL of greater than 0.4 and still have their wits about them. So just keep in mind that this particular chart is used really only for legal purposes, not for clinical purposes. It does us no good in the field in knowing this information because we don't know the effect of or the strength of tolerance. And I'll talk about tolerance in a minute. Okay, but the whole emphasis here is on the neurobiology of addiction. So I pull from Stahl on these particular slides. I want to talk a little bit about the biology of addiction. And as you can see at this slide at the top, the mesolimbic pathway starts at the bottom there. That little dot is an area called the VTA, the ventral tegmental area. And then there's a whole group of neurons that bridge the VTA, and at the end point is the nucleus accumbens. The nucleus accumbens being the pleasure center or the pleasure-seeking center of the brain. So that's important to know, because when the VTA is stimulated and those neurons light up, that creates or causes the release of dopamine, which biologically is our definition of pleasure, satisfaction, happiness, contentment, all of those. So one thing that we do know biologically, every time you get a pleasant thought and smile, or you feel good about yourself, or you hear a funny joke and you laugh, one thing that we know is this area lights up and dopamine is released. So our feelings of satisfaction are the result of this area lighting up, not the cause of the area lighting up. So keep that in mind as we continue. So generally, anytime we do anything that makes us feel good, makes us feel happy, that area lights up. Now the downside is, anytime any substance of abuse is used, the same area lights up. Only here's the kicker. That area lights up between 10 and 100% stronger than your most pleasurable experience. So you can certainly understand why people who at first begin experimenting with drugs and have what we believe theoretically are the genetic predisposition to addiction, then the euphoria experienced is absolutely tremendous, and people just want to recreate that over and over again. So it's another important statement about the whole use of drugs and how it feeds into our happiness center, our pleasure center. The other important thing to keep in mind that I want to point out is people often ask me whenever I give a presentation on the drugs of abuse, how is it that controlled substances end up on the controlled substances list? How does that happen? And the very, very simple answer is if they're ever found at the VTA into the nucleus accumbens, then they become a controlled substance. That's the simplified explanation. Every single drug of abuse will end up here and have the potential for causing addiction, and therefore will become a controlled substance. So that's the simplified answer for that's the schedules, the 5 schedules that we currently have. Now I'm going to take that the mesolimbic pathway as you see it at the top of your screen, and I'm going to shoot it down to the level of a single neuron. And this neuron is a graphic of a neuron in this particular mesolimbic pathway. And on the left is going to be the ventral tegmental area, and on the right you see the postsynaptic neuron that's in the nucleus accumbens. And again, this is I took this from Stahl, and I think he does a really good job in explaining a whole number of things, which I will attempt to replicate. First of all, alcohol. Alcohol affects the GABA system, and when alcohol hits GABA receptors in the VTA, it causes the release of dopamine at the end of the presynaptic neuron. Dopamine release will hit the dopamine receptors, and the person will experience euphoria or pleasure. The same thing with cannabis. Marijuana hits the cannabinoid receptors in the VTA, which also causes the release of dopamine, as do the opioids hit the mu opiate receptors that are also located in the VTA, and once they're stimulated, cause the release of dopamine. Whoops, I did something crazy here. Let's go back. Sorry about that. Okay, first mistake. Got it out of the way. All right. So nicotine is also, as we know, is a drug of abuse, and it hits the it follows the acetylcholine receptors. You can't see the ACH there on the left because it has a white background, but nicotine follows the acetylcholine receptors, which also are located in this area and do the exact same thing, as do the hallucinogens. The hallucinogens follow the serotonin system, the 5-HT system, and again do the same thing as does PCP, and also alcohol works with the glutamate system. That's not glucose, that GLU, that stands for glutamate, which also causes the release of dopamine and hitting the receptors. So one thing that this graphic shows very, very nicely, I think, is that all drugs of abuse, all of them, there's a few up here that a few that are not on this particular graphic because I couldn't get them all in, is that they all end up here. They all end up stimulating these neurons and cause the release of dopamine in the nucleus accumbens, where the dopamine receptors are stimulated, and the end result is the feeling of euphoria, pleasure, and great satisfaction. So that's an important thing to remember. The other thing is, one thing you notice that the psychostimulants are not up here. Here they are all the way close to the nucleus accumbens. And one thing we know now, the psychostimulants, which include amphetamine, methamphetamine, cocaine, crack cocaine, all of the prescribed psychostimulants, Ritalin, Concerta, Adderall, Vyvanse, all those guys, they kind of bypass this whole area and go directly to the nucleus accumbens. And initially, we thought that the only thing that they did is acted as SDRIs, as specific dopamine reuptake inhibitors, in which they hit that presynaptic active transport area there and prevented the dopamine from being sucked back in, and therefore with all the extra dopamine it would continue to hit those receptors. And in fact, that is true, but there's a second part. The second part is that the psychostimulants do something even more dangerous. They're able chemically to reach into the presynaptic neuron and rip out additional dopamine. So not only do they prevent the dopamine from being sucked back into the presynaptic neuron there, but they're able to chemically reach in and drag out actively more dopamine, so that there is just a complete saturation of dopamine molecules hitting those receptors over and over again. And so one of the things that we know because of that particular process is that crack cocaine, once it's inhaled, goes through the lungs, to the pulmonary system, directly to the brain, right to the nucleus accumbens, and hits those receptors, fills those receptors up with dopamine. And therefore, crack cocaine is right now believed to be the most addicting substance. Now, some experts will say nicotine is, mainly because of the number of nicotine addicted folks in the world, but that I think most experts will say, well, that's because of the availability of nicotine, not because it is more addicting. Another thing about nicotine that I want to point out to you, and the nicotine receptors, and why public policy doesn't push so much against nicotine as it does the other drugs of abuse, is that nicotine, as I said, hits the acetylcholine receptors, and there's something very, very interesting about the acetylcholine receptors in the VTA, ventral tegmental area, and that is the fact that the acetylcholine receptors, after a short period of time, desensitize. And so it just so very nicely, and that's probably in about 95–96% of the population. So 95 to 96% of smokers that smoke generally only need, at any given time, 1 or 2 cigarettes to satisfy them. And that's because after that period of time, that nicotine has desensitized the acetylcholine receptors, and the person doesn't need any more nicotine in their system. It takes, by the way, a couple hours for those receptors to resensitize. And it's convenient at that very time. It's break time for most of these folks, and they go out on break and have another cigarette or two and are satisfied until the next break time. So it's kind of self-limiting. The acetylcholine receptors kind of self-limit the progression of nicotine use. Now, we know that there is a percentage of the population also in which the acetylcholine receptors are not desensitized, a small percentage, and those folks we know as the chain smokers, because they continue to need more and more nicotine to stimulate those receptors. So that's that particular graphic. The other important thing that I think this graphic demonstrates is the whole idea of cross-addiction. And it does this very, very nicely. One of the things that this particular graphic does not show is the area surrounding the nucleus accumbens is an area called the hippocampus and the amygdala, which are kind of like the emotional memory centers of the brain. Now, we know the cognitive memory centers are pretty much housed in the cortex, in the cerebral cortex, but the emotional centers surround the nucleus accumbens, and there are association fibers that go from the nucleus accumbens into those particular areas of emotional memory. So, for instance, let's say we have somebody that's addicted to heroin that goes in for treatment and gets that pretty much resolved and is in sustained recovery and does not use opiates anymore, but has decided to take on either alcohol or marijuana or something like that. Those alcohol and marijuana end up in the same places as the opiates did, stimulating the nucleus accumbens. And what happens is, once the nucleus accumbens is stimulated, association fibers go back and forth into the amygdala and hippocampus, and pretty much the brain asks itself, when have I ever experienced this level of pleasure? And immediately what comes to mind is the feeling, not the thought, but the feeling of what it was like to be high on opiates. So either the alcohol and or cannabis addiction will start up, and and a great potential of opiate relapse will occur because of the emotional memory center being stimulated, and that feeling of euphoria will create craving, and then off we go. Now we have a polysubstance dependence, where previously we had just an opiate dependence. And this is probably even a bigger problem iatrogenically. We find that a lot of alcoholics and a lot of opiate addicted folks that are in recovery go to their doc for one reason or another and end up walking out with a prescription for Xanax. This is a very common and problematic issue for us that work in the field. And what happens more times than not when these folks come back to us, not only have they relapsed to their original drug, but now they have a primary addiction to the benzo. So this, again, is a big problem for us. So this pretty much explains, so far, part of the biology of addiction. Now there's a lot more to it. I'm simplifying it, but maybe I can give you some more slides and give you some more information as we go along. Here are the drug categories. Everybody pretty much is familiar with them. Really, the feds are the ones that come up with this list, and they pretty much like to push every new drug of abuse into one of those particular areas, and I just throw that up there just for general information. This is another slide of some examples of addicting molecules, and on this slide I have nicotine, alcohol, heroin, and cocaine. And the take-home message here is, look how different they are. It would be one thing if these particular drugs looked a lot alike, but they don't. Each one is completely different from the other. And most people will say there has to be some different rationale or reason for addiction. Well, the previous slide, the graphic, pretty much demonstrates the explanation, in that all of these different addicting molecules hit or utilize a different neurotransmitter pathway that is specific for them, or is part of that whole process. So the graphic that Stahl gives us is a very nice explanation for why so many differing molecules can have such a similar effect on the addicted person. So is there a single pathway to addiction? Drugs of abuse have very different structures and neurotransmitter targets in the brain, as I just explained, but they all exhibit certain commonalities. And that is this list here, this bulleted list. There is acute reward. Obviously, when the person first starts using it, they experience such a euphoria, such a high, that what they want to do is continue to re-experience that over and over again. We have chronic reward. We have sensitization of the receptors, which I will talk about in a little bit. We have negative withdrawal symptoms that occur with all of these, pretty much. There are some that we've been unable to identify with a true withdrawal syndrome. Associative cue learning. You know, this is big with the 12-steppers, with people, places, and things. So associative cues themselves can cause relapse and not. So that's the external part of the relapse process. And then relapse itself, which also is given the name incentive motivation, or relapse. So the progression in addiction is from an impulsive state to a compulsive state of drug use, which basically defines the progression from abuse, and previous to that, experimentation, misuse, and social use and all that, right into full chemical dependency or addiction. So keep that in mind. Now, this is just some informational slides for you, the next two. The body's own psychotropics. The brain makes its own morphine. It really does, called beta endorphin. It makes its own marijuana, called anandamide. Keep in mind, we wouldn't have the receptors that these drugs can hit if we didn't have an internal neurotransmitter to stimulate them. So we didn't evolve into having all of these different receptors in the brain with the knowledge that they were put there because someday they'll be useful in addiction. That's not it at all. All those receptors have a corresponding neurotransmitter. We just haven't found a good number of them yet. The brain even makes its own antidepressants, anxiolytics, and hallucinogens. Whenever we are able to close our eyes and creatively see things in front of us and imagine things, that is the use of our internal hallucinogens, really, that in a controlled way help us see things that aren't really there. Drugs often mimic the brain's natural neurotransmitters, so we pretty much demonstrate that with the graphic. And often drugs are discovered prior to the natural neurotransmitter. For instance, we knew about morphine before the discovery of beta endorphins. We knew about marijuana before the discovery of the cannabinoid receptor and anandamide. We knew about the benzos like Valium and Xanax before the discovery of the benzodiazepine subreceptors. And of course, we certainly know about Elavil and Prozac before the discovery of the serotonin transporter site. So what has generally happened in the past with the manufacture of drugs is we observe the behaviors that the drugs cause because we didn't have the technology to figure out what they do in the brain. We're getting closer and closer to better understanding how these drugs work. Transition to addiction. Taking drugs may begin as a voluntary choice to seek a pleasant stimulus. But for addicts, that choice is no longer volitional, even in the face of terrible personal consequences. So pretty much everybody in the field will state, when you first start using drugs, when you first start using them, you're experimenting, you're using them socially, it's a choice. Basically, everybody believes that. When you first start using, it's a choice. But for those that are prone to addiction, it's no longer volitional, it's no longer a choice. Most of our population have a real difficult time understanding that concept. The way that I like to explain it when I talk to patients and families, and even to folks that don't work in addiction, is the whole idea of craving. In addiction, we have a differing definition for craving than they do in the general population. So when we talk about, when we're outside and we talk about I crave chocolate cake or chocolate ice cream or whatever, that has a different meaning than to the addicted person. We can delay gratification for whatever it is we feel like eating. You know, one of the best bakeries in the area you're walking by and you decide to go in and buy something, but you're going to wait till after dinner and have it for dessert. You can do that. The way that we describe, or I like to describe craving in the addicted person, is that craving is more like the worst migraine you ever had or the worst tooth abscess or tooth pain that you ever experienced. And you're experiencing this feeling, which is horrible, absolutely horrible, and you know that the absolute only thing that will take away that pain of craving is the drugs that the person was using. And nothing else goes through their minds. And I'm sure many of you, I know I have experienced migraines in my life, and I know that I need to stop absolutely everything that I'm doing. I need to go into a quiet room, shut the lights off, and I know that, assuming that I can catch it in time, is take medication and specific medication that will stop the migraine. And nothing else matters while I have that full-fledged migraine. Well, it's the same thing as in the addicted person when they experience these tremendous cravings. Once they start, they know they will not stop until they can get their hands on whatever drugs they were using. So that's an important thing to keep in mind. I'm going to talk a little bit about tolerance, withdrawal, and dependence here. And here's some biology for you. I don't really expect you to remember most of this, but we're in a time when we're really looking toward biology and physiology for some explanations. And here's a nice theoretical definition of tolerance. When we have dopamine release, generally as a result of bringing in exogenous drugs into the system, dopamine receptors get stimulated. And when those receptors get stimulated over a period of time, there's the activation of cyclic AMP. So the neurotransmitter is what's called the first messenger, and the cyclic AMP is a second messenger that's inside the cell. And what that does is that migrates from the inside of the receptor down into the nucleus, and it activates a protein called Krebs. Now, that has nothing to do with the Krebs cycle that many of us were forced to memorize in undergraduate. It's called camp response element binding factor, or protein. And what that does is it activates another enzyme called dynorphin, or neurotransmitter really, dynorphin. And what dynorphin does is it migrates back to the receptor that's being stimulated and desensitizes, specifically the dopamine receptors. Now, in the old days, we talked about, I'm sure you've heard the term downregulation, in which the receptors begin to disappear. Well, now we know that from within the cell, this dynorphin is desensitizing those receptors, and so they're not lighting up when they inject radioactive material. So the belief was that the receptors themselves were decreasing in number, when in fact they are being desensitized and they're not no longer working. So as dynorphin increases, so as more and more drug is taken, more and more dynorphin is released, and more of the receptors are desensitized, which means that less and less of the receptors that are left are available for dopamine. So in order for those receptors to be found by the dopamine molecules, there has to be a lot more dopamine. So what happens behaviorally is that the person ends up needing to take more and more of the drug, so more and more dopamine gets released to hit those handful of receptors that are left that the dynorphin hasn't quite hit. And then resensitization occurs with the activation of yet another enzyme. It has a funny name, delta phos B is the name of that, from the phos B groups of enzymes or transcription factors. So it's delta phos B that increases also in the system, which resensitizes the receptors, but it does not decrease the dynorphin. So the dynorphin and the delta phos B pretty much are in conflict in the cell itself. And we know that in addicted populations there is an increase of the delta phos B that generally isn't found in non-addicted populations. So that's tolerance from a biologic point of view. Now, withdrawal, predictable constellation of signs and symptoms followed by abrupt discontinuation or decrease over a period of time, and we know that, for instance, that each class of drugs has its own withdrawal syndrome. Now, biologically, so the DSM gives a very nice, and this is pretty much taken, it's adapted from the DSM, gives us a definition of withdrawal, but it's behavioral. It talks about a behavioral definition. The biologic definition of withdrawal is merely the substance of abuse falling off the receptors, or the neurotransmitter itself falling off the receptors. That will cause withdrawal. That act, that biologic act of the inactivation of the receptor because the drug or the neurotransmitter is falling off and being destroyed or whatever. So there's two definitions. The DSM gives you behavioral, and there's also a biologic. Now, I just want to, I'm not going to read all of these, but all of the, and I'm sure I'm preaching to the choir here in knowing what the withdrawal symptoms are for the major classes. And basically, when students see this list, they get frightened that they have to memorize it. And I just tell people it's like a bad case of the flu. That's all that opiate withdrawal is like a bad case of the flu, whereas depressants, we have anxiety, insomnia, tremors, delirium, possible seizures, possible death as a result. So withdrawal from depressants, for the most part, requires medical management. That's not something that we want to tell folks they can do at home. they really need to be under medical monitoring for fear of delirium, seizures, and coma and death. The stimulants, apathy, hypersomnia, irritability, depression, orientation. So obviously during the withdrawal phase of a severe cocaine addiction is when the person is very, very depressed and is most prone to suicidal ideation. So we always have to worry about that. Also, cannabis, there's just a few of the withdrawal symptoms for you. And hallucinogens, oddly, unknown. We can't identify a particular syndrome that's statistically significant in folks that are addicted to hallucinogens, because everybody experiences the withdrawal syndrome differently. So we can't really conclude that there is one, or if there is one, it's quite variable in different people. This is a slide that I like to use when I talk to the ER folks and to the primary care docs and all those. And basically, and not 100% now, but basically we have a list of drugs, new drugs coming onto the market that are out there, that for even those ERs and primary care docs and even addictionologists and drug and alcohol centers, when they pull urines to test, a lot of these drugs will come up, will not show in the common urinalysis, urine drug screens. So it's very, very possible that people will present with symptoms that are in the last column there, marked risks, and you pull a urine because you think maybe this is substance-induced, and it comes up negative, and so you treat the symptom when really the person has been using, for instance, ketamine or methadone or even LSD. We don't see in a lot of the panels, unless we ask specifically or get the expanded panels. GHB pretty much will come up in a lot of the panels, but MDMA may or may not in some of the panels. Ecstasy may or may not come up. So just be familiar. My point with this slide is that people may present with symptoms, and you're diligent enough and prudent enough to pull a urine and test it, and it comes up negative. What we need is collateral information to see whether or not they possibly could be using other drugs. Post-acute withdrawal syndrome, be familiar with that, because here again, these folks will primarily show up either at the general psychiatrist or the primary care doc presenting with these symptoms. And as I say, even if they are well enough informed to ask for a urine sample to test it, it's going to come up negative if they've been clean, because we know that post-acute withdrawal can last up to 6 months, and for most of the drugs, they're out of the system, very, very shortly, in a week or two tops. So they'll come in with, we'll take the last one, poor concentration, attention deficits. These are the folks that may very well get misdiagnosed as having ADD. And be put on a psychostimulant, which will then activate that craving center again. So, and also the insomnia, they'll show up with that, and the docs will prescribe a benzo, which is never any good for this population. Dependence, I take this right from, I figure it's nice when we're talking about addiction just to make sure everybody's on the same page as to what the criteria are, even though they're changing a bit in the DSM-5. We're going to go over, and I take this right from the DSM. I want to point out physiologic dependence, evidence of tolerance or withdrawal. That's criteria number 1 and 2, which by in and of itself has created a lot of problems in the community, especially with the folks that are taking or really require, that are non-addicted folks who require pain medication or anxiety medication and refuse to take them because they're afraid of becoming addicted. And as a general rule, people that take anybody, this is anybody, that's given a controlled substance by, let's say by prescription, because we're talking about illicit use here, that take any prescribed controlled substance and use it every day for at least a month. If you stop cold turkey, you're going to have withdrawal symptoms. That's a given. that withdrawal and that level of tolerance that they may or may not experience is not considered pathology. So physiologic dependence in and of itself is not pathology. It's a variant of normalcy, and what gets people confused is physiologic dependence is included as part of chemical dependence, and so they have a difficult time differentiating the two, but there really is a difference there. We have the psychological dependence criteria, which we call the 3 C's: loss of control, compulsive use, and consequences of use. And loss of control are criterion number 3 and number 4, substances taken in larger amounts over longer periods than intended. Unsuccessful efforts to cut down or control substance use. Generally, we find this in actively addictive populations will meet these 2 criteria very easily. Compulsive use, number 5. Now, criterion number 5 is pretty much the criterion that we use to measure severity, because the more the person spends looking for the drug, using the drug, and crashing or recovering from the drug's effects, the more severe the addiction is. So obviously we know that somebody that only uses Friday nights and gets up and goes to work Saturday morning is not as severely addicted as somebody that's using 7 days a week, and the only thing they're interested in doing, their whole life revolves around going out, finding the drug, and maintaining an inventory, using the drug, and then finding a safe place to recover from the effects. So that's very, very severe, and that's probably the take-home for going over these particular criteria. Number 6. Important social, occupational, recreational activities are given up or reduced. This goes hand in hand with 5. Obviously, the more time you spend finding, using, and recovering from the drug, the less time you have in doing anything else. So they're kind of on the opposite sides of the coin there, 5 and 6. Number 7, basically everybody meets. You know it's wrong, but you do it anyway. You know it's bad for you. We don't talk about wrong, by the way. We talk about it's bad for you, it's unhealthy, it's dysfunctional, whatever. But DSM pretty much likes to stay away from right and wrong in these issues. Progression. So know that there's an initial stage of addiction. Pleasure derived from various drugs, activation of the brain's natural reward system promotes continued drug use. So that's initially what happens. You get this feeling of euphoria, and you want to keep re-experiencing it. However, repeated exposure induces the brain's mechanism for dependence. That's from the delta phos B, and then also from the dynorphin, which increases tolerance. Dependence leads to daily drug use. For the main purpose now of averting unpleasant symptoms of drug withdrawal. So one of the things we know about chronic addiction that differs from acute addiction is in acute addiction, you're going towards the feeling of euphoria, and in chronic addiction, for the most part, although you're looking for that euphoria and you do experience some, you really are working to avoid withdrawal. So that's what's going on there. Stress. More and more we're finding out how really much stress affects cravings. And that's basically what this slide demonstrates. And it revolves around cortisol. Obviously, we know that cortisol is involved in stress mechanisms, and cortisol is increased in this population. Genetics, 40 to 60% of all possible causes of chemical dependency relate to genetic vulnerability. So that means that there are unknown non-genetic contributing factors that account for the remaining 40+%, which causes chemical dependency. So we know that there's internal factors, or theoretically, that there are internal genetic predisposition factors, and there are also external traumas or stressors that add to chemical dependency. And the one thing that we know that makes it really, really complex for us is that chemical dependence is genetically heterogeneous, which means that a whole bunch of different genes are involved and affect, even in the family tree and the family line. one of the things that has been discovered is if a parent has an addiction and they look at those genes, and you look at the child with a similar addiction and look at those genes, they could be different, completely different genes that have been affected. So that makes it a little more complex for us. Biologic models of addiction I'm going to go through really, really quickly. There are several variants and are based on altered neurobiology of dopamine in the VTA and also norepi in the locus coeruleus. So a lot of these, this particular model, which is the changed set point model, of which there are a bunch of variants that I want to talk about, that are theoretical models or concepts for addiction. So the first variant says that neurons in the mesolimbic reward pathways, you saw that on that graphic that I showed you, are naturally set to release enough dopamine in the nucleus accumbens to produce normal levels of pleasure. So we have like a thermostat normally in that area to gauge our level of experiencing happiness, pleasure, satisfaction, contentment, that type of thing. Now bring in abused drugs, which causes addiction. That changes that thermostat. So now dopamine is reduced when there's normally pleasurable activities or events that occur. So the person that's addicted to any substance experiences in normal situations less secretion of dopamine and therefore less feelings of pleasure. So the change that also occurs in the locus coeruleus, which is the center point for norepi, and so when somebody experiences withdrawal, the belief is that there's an increase in norepi, just as there's a decrease of dopamine in the nucleus accumbens, there's an increase of norepi in the locus coeruleus, which accounts for the withdrawal aspects of addiction. So that's one variant of this change set point model. Another variant is that dopamine neurons can become dysfunctional through alteration of their resting levels of electrical activity and dopamine release. Another point that we have discovered is that even in resting stage, dopamine is still secreted into the synaptic cleft from the presynaptic neuron and stimulating the postsynaptic neuron, and we basically understand this as being in an aware state of general satisfaction, not overly happy but neutral, and that is explained by the fact that even in the resting state, even without us experiencing any level of conscious satisfaction or pleasure, that dopamine is being released. Well, that changes in addiction. So, and here in this second variant, we're bringing in glutamate and the use of the autoreceptors. Autoreceptors are on the presynaptic neuron, and for instance, when there's too much dopamine released, the brain says there's too much dopamine, the dopamine will hit the receptors on the presynaptic neuron, which act as brakes, which turn off the release of dopamine. So with continued use, there's an increase in the number and strength of those autoreceptors, which again leads to the decrease in free dopamine in the synaptic cleft. So that's another model that's out there. And the third one emphasizes the sensitivity to environmental cues. So here we're bringing in outside influences, environmental cues, which can also lead to that. I'm not going to read that because I'm just about out of time here, so I just want to talk about types of craving. There's cue-based, state-based. Now, notice that on both, opiates are not mentioned. That's because opiate cravings are both cue-based and state or stress-based. So you get a double whammy with opiate addiction in that environmental cues can cause relapse, but also internal emotional cues can also do the same thing. And this is just another model. This is the cognitive deficits model, which you can download these slides and you can read this. But basically, it talks about the prefrontal cortex as being involved in the whole process of addictions. So that pretty much ends the presentation, so I can open it up now for comments and questions if you have any, and I'll turn it back over to Dr. Fennell to farm out those questions.
Thank you, Dr. Lerman, for an excellent and informative presentation. I do want to remind you that there is a way to submit written questions in the control box on your computer screen. And before we go to that, I have a couple that came in while you were presenting. Can you hear me, Dr. Lerman?
Yes, I can.
Okay, great. So one of the first questions that came in is, and this is probably a whole nother series in and of itself, but how does pregnancy affect the neurobiological response?
That's a very complex question, because we know that hormones themselves play a role in the whole psychiatry and neurotransmitter functionality in the brain. So I think I'm going to leave it at that the hormones and the change in hormonal levels throughout pregnancy change addiction and how it affects the individual.
Mm-hmm. Maybe a good topic for a future presentation.
That sure is. I could talk for an hour and a half on that.
Okay, another question, and this came to mind as I was watching, perhaps this questioner did as well, 60 Minutes the other night, where there was a presentation about the sugar epidemic in our nation. So does any research support the idea that sugar produces a similar response in the brain for a portion of the population?
Well, that's a good point. Again, in those folks that have the theoretically predisposal genetically to addiction, then sugar content, the glycemic index, does have an effect in that area and will hit pleasure centers. Certainly, when you have a really good piece of New York cheesecake, and it's just absolutely delicious from the very first piece to the very last, we feel very, very satisfied, very happy. We know biologically that dopamine's being released in the nucleus accumbens. But because we're not, for the most part, genetically predisposed, it has no further effect. But in those folks that are genetically predisposed, it does cause the association fibers going back and forth in the amygdala and hippocampus, and certainly will affect that whole addictive cycle.
Good, thank you. Another question, I've heard that cravings are shown to last only about 60 to 90 seconds. Is that true? I also describe cravings to my patients as the cravings hijack your brain.
No, cravings actually, in addiction, cravings will last much, much longer. It certainly is a physiologic factor of stimulation in the amygdala of that feeling memory, of that emotional memory. Certainly in the general population, you're walking past the bakery or you smell cookies being made. You crave them, but then your prefrontal cortex will distract you into other things going on around you, so that craving will dissipate very rapidly, but not in the addicted person or the chronically addicted person. It will not.
Okay. And I think you mentioned this as you were presenting, but your reference for slide 1 on the statistics, did that come from the World Health Organization?
Oh, actually, I erred. The first slide actually came from SAMHSA.
Okay.
The second slide, the disabilities, came from the World Health Organization.
Okay. All right. So SAMHSA is our Substance Abuse Mental Health Services Administration, and that's easily accessible information on the website, on the SAMHSA website, correct?
Correct. That's where I got it from.
Okay, great. Next question, is PAUSE accepted as a diagnosable syndrome by mainstream addiction scientists or researchers? Is it measured through brain scans or other methods that would lend credibility that pause is in fact a neurobiological syndrome?
Well, addiction specialists recognize pause as a separate diagnostic category. That is correct. And for the vast majority of us, we rely on behavioral factors and not biologic factors because we really don't have the availability to measure that. But in fact, it is measurable, and certainly there have been measurements done down at NIH and other places that you can access the literature on to authenticate the whole idea of pause. For the longest period of time, pause was believed just to be a figment of imaginations of some addictionologists, but now we know that in fact it's not.
So there is some evidence base there,
Yes.
Strong evidence base for that.
There is.
Good.
There is.
Considering the role of dopamine receptors, do antidepressants have a role in the recovery phase for those addicted to opiates?
Well, one of the nice things about the antidepressants is that they generally do not have much of an effect on the nucleus accumbens. So even the ones that work to prevent or inhibit dopamine reuptake inhibition, like bupropion, they do not go into the nucleus accumbens actually. So no. Remember, when we give antidepressants and when we treat any psychiatric problem, we're actually treating the symptoms and not the disorder itself. So it's the symptoms that we're trying to alleviate. So when we see severe impairing depression itself, it's really not because of the lack of dopamine in the nucleus accumbens. It's the lack of dopamine or other neurotransmitters in other areas of the brain. So the antidepressants, in fact, will affect the depressive symptoms that you have, but not alleviate any of the addiction or chemical dependency urges, cravings, or anything else. I hope that answered the question.
And maybe kind of another question that came in related to that might help to expand on this is in your the model that you presented, the change point model. If we have an internal thermostat to gauge, what happens to the person with depression? And that may be, I think when you were talking about the internal thermostat, you were talking about kind of the switch that gets flipped with people with addiction. So is there something similar in terms of depression?
Well, again, these are theoretical models, and yes, there are theoretical models around depression itself. Initially, the model was there wasn't enough of the neurotransmitters of serotonin, norepinephrine, or a combination, and then the model that followed is that it really had to do with the number of receptors that were available. So basically, in somebody that is depressed, one of the things that we know is that there are a lot more of the receptors that are activated, and either it's because there could be a whole reason why that is. It could be a similar situation, similar to the dynorphin, that inactivates receptors that are already there, and that in the absence of neurotransmitters, the dynorphin pulls away and reactivates them, and that's what causes the depression itself, whereas a dynorphin-like substance, as it inactivates in depression those particular receptors, depression resolves. So that happens to be the current thinking with depression, is that it's not the neurotransmitters primarily in and of themselves, but the number of receptors. So when there's a lot of receptors around there that are active, we experience depression. When those receptors are turned off to what I guess we would call, I hate to use the word normal amount, then the depression resolves. Now, what we don't know is exactly what it is that deactivates the receptors. So we could use a model similar to the dynorphin model, but that's never been, and it has been postulated, but we have no information on that I'm aware of.
Okay. So clearly points out the need for, I think this is raising some identification of future topics that perhaps people would be interested in. I think our time is up. We do have a number of questions that we haven't had the chance to get to. And as I talked about at the beginning, Dr. Lorman has graciously agreed to answer those questions offline, and we'll include those on response out to the people that participated in today's webinar. So I want to take this time now to thank you all for participating in the webinar. Dr. Lorman, again, thank you for your presentation. It was very informative. You will receive an email from the American Academy of Addiction Psychiatry that will include a link to the evaluation survey. And do take a few minutes to access it and provide your feedback on today's session. The webinar today was recorded and will be posted on the International Nurses Society on Addiction's website, which is intnsa.org. And it will also be posted on the Physicians Clinical Support System Opioid Therapies. Those slides will be in the webinar will be posted in a few days. The website for the Physicians Clinical Support is www.pccs-o.org. And we'll have that information, and it was in your webinar invitation as well. We will have a calendar of upcoming events and helpful clinical resources. Those are posted on the PCSS website, and we will be scheduling more webinars in the very near future, so please stay tuned for future intervention webinars. We really hope that you'll join us for those, and again, we thank you for your time today. And that ends the webinar. Thank you.